wanting to recommend the profession to their children. What's going on here? What's changing in the profession? Let's take a look at that. And so we started a brand new unit. I was one of 2 individuals to kick off a brand new unit, and we sort of looked at each other like, what are we going to do? We don't know how to solve this problem. We didn't even know what the problem really was. So we partnered with Rand Health to do a mixed method survey to really understand the factors that dissatisfy physicians. And, we're a little, we're academics, and so we really think we're smart, so we use previously validated survey instruments, which when you're in academics, you want to use a previously validated survey instrument. So it was a good thing it was mixed methods, because our qualitative work, our interviews really highlighted EHR as a major problem, but our quantitative survey, because we were leveraging surveys that may have been 4 or 5 years old, didn't have any questions on electronic health records. We weren't even asking about it in our survey. But what resonated in those qualitative interviews was this issue around the time and the time sink and the burden of the electronic health record. And so over the next 10 years, we've been tracking burnout, which peaked in 2014, and as you noted, Kathy, it was going down. It was actually going down, and it actually went down even into the beginning of COVID, which was a little bit of a surprise to us. Why was burnout down in the first 6 months of COVID? And we're really talking about a time when the healthcare profession was coming together. People are banging their pots and pans for clinicians. We're so proud of what they're doing. But by 2021, burnout had completely flipped and was at the highest levels that we had seen, due to a lot of the reasons that Kathy mentioned, including staffing shortages. We all know about, it's harder to recruit. Everyone's got open positions. The politicalization of healthcare became something new, everything from vaccinations to reproductive rights. And the electronic health record continued to be burdensome because that is the point of interaction for physicians. We see inbox messages increasing about 140% coming out of COVID, as we're pushing more patients to interact with their patient portal, which is wonderful care, but increases the number of messages on top of a busy schedule for physicians. So we know the electronic health record is an issue. And there's a clinical psychologist named Frederick Herzberg who talked about what made job satisfaction. He talked about motivators and hygiene factors. And the motivator factors made you satisfied. And the opposite of satisfaction is not dissatisfaction. The opposite of satisfaction is not being satisfied. The opposite of dissatisfaction is not having dissatisfaction. And these hygiene factors are things that won't make you satisfied, but if they are there, they make you dissatisfied. So if you have a bad relationship with your boss, if you have a bad relationship with your colleague, that's going to dissatisfy you in the workplace. But having a good relationship with them may not make you satisfied. I consider the electronic health record as a hygiene factor, meaning if you've created a situation where they work well, that doesn't necessarily mean your clinicians are going to be satisfied. That's driven by advancement, recognition, doing purposeful work and being recognized for it. But if you have these hygiene factors, like an electronic health record experience where there's increasing work outside of work, that maybe you don't have a good system, you're not tap and go to log in, you don't have good team-based care, that's going to be a real burden. And I know our colleagues here on the panel are going to highlight some great examples of some things that they're doing.
Great. Thank you so much. That's a great way to put it. We often call that the pebble in the shoe. Like, what's that one thing that's going to tip you over the edge? And that seems like what you're saying there. Like you mentioned, our panelists all have some great examples and work that they've been doing on burnout, and we'd love to hear from them as far as what they've been doing in their organizations that we could learn from. Who would like to start with their story? Dr. Magoo, you're right in the middle.
Sure.
We'll put you on the spot.
Thanks, Kathy. So just a little bit about Yuma. So it's a border town at the corner of Arizona, California, and Mexico. It's a very difficult place to recruit, as you can imagine. It's hot, very, very hot. I left, it was 117 degrees, although they say there's no humidity, but when you're in the ambulance going to the ER, you can tell your paramedics that, I'm from Atlanta, there's a lot of humidity there. Anyway, so we have a large medical group. It's a 300 plus providers in the group, including APPs. It's an integrated system, 40 locations, 1 hospital. And we were, in 2016, trying to find opportunities to decrease our attrition. We know it's challenging to recruit providers, but I think even more challenging to keep them there. Our physician engagement surveys year over year always had the number one challenge is the EMR and the time providers spent on the EMR after they're out of clinics or the hospital. And we just couldn't get any mitigation strategies that were successful. We had super users in every department in all around the hospital and the primary care network. But as the previous speaker said, super users make you more efficient in using the tools which are already there, but not changing the tools. They don't have the ability to change the tools. In 2018, the previous CMIO really brought in a suggestion that we really need physician builder program to really have a positive impact. Now, there was a lot of questions, how do we compensate for their time? Is it, do they get compensated as a timesheet in addition or just the time? We took it to the board and deliberated on that for some time. And finally, we started a program. We had one primary care physician who was a super user before, took the lead and got trained, got certified in 6 months. Within the first 9 months, we saw extremely dramatic rapid cycle improvement, especially in the large primary care area where he was working. And followed by that, we had 4 other super users who got certified over the years. In 3 years since the program is in place, I'm just going to give a few examples of the things they have done. I think the goal for the governance of that program was to reduce the provider's time interacting with the EMR. That was the overall goal. How many less clicks, how much time they spend, the length of their notes. This was the overarching goal. So, the few examples of successes were the Medicare wellness note length went down from 6,000 characters to 750. CPT2 codes automation, HCC redocumentation BPAs, medication refill automation, and the charge capture for other things. And there's just a list of items. And these are all done the last 3 years without any significant involvement of IT analysts. And that reflected in the physician engagement surveys. We have now 1/3 of the attrition rate of community hospital. We are 8.5%, and the community hospital around 21. And now we have a list of physicians or in APPs who would like to certify as physician builders. I think we are looking at around 9 builders for the entire medical group. Thank you.
Wow, that's super interesting. How did you, just as a follow-up, so how did you get the news out about the physician builder and what the changes were being made? How did that go out as far as the implementation?
So I think as I mentioned before, the scope of the physician builders is something which already exists in the Epic universe, which they can take and implement in the system, so that the change control remains under the ITSC and through the analyst, but the least amount of involvement with IT. So all the projects coming out of the physician builder program still go through the same governing structure.
Okay.
But the key there is because they are directly involved in the front lines, so they know what are the pain points. So when they conduct their own surveys and figure out, if in our largest primary care practice, he already knew what were the top 4 challenges. So
And then he just taught his people in the...
Correct. So when the pilot was successful, then it went around all the 23 primary care locations all around. So, and then it became our news flash from our CMIO, which came out every month.
Great, thank you for that follow-up. Candace, can we go to you next and kind of hear what you guys have been doing at Honor Health for the nurses?
Yeah, thank you. So similar stories from a nursing side of the house, and similar to all the other stories that I've heard from other organizations on the acute hospital side. Our success story, and it all started with our time we have our Epic system, time spent, and this is pre-COVID, in a 12-hour shift, averaging about 190 minutes, so it was pretty significant. We were at the bottom quartile. So really there was a heightened awareness and engagement from our executive nursing leadership. You know, we have to do something, and so we made it a priority. And shortly thereafter, COVID happened, but we still had that engagement and executive support to continue on and at least get to the mid-quartile or better if we could. So that was kind of what we were shooting for. We heard loud and clear from our nurses. They wanted changes, and the changes that they did put in kind of went into a black hole. So we kind of had just to re-engineer the whole entire structure, governance structure as well. So knowing that we're still going to have optimization requests coming in, but yet we have to, forge ahead on this project to make improvements. So we partnered with our IT colleagues, our frontline, so we had great engagement from our frontline staff. We probably had about 50 to 60 representatives from nursing, frontline, all the various service line areas, clinical directors, CNOs. We would meet every 2 weeks, and we had a cadence, at least for the first 6 months, just to focus on prioritizing our admission history and getting that shored up, because it was pretty much everything in the kitchen sink. Everybody from all other ancillary divisions wanting us nurses to do, XYZ activities during the admission process. And then also focusing on the high utilization flow sheets, vital signs, INOs, head-to-toe assessments. We know that needed attention as well, too. So as mentioned, using rapid cycles of improvement, PDA cycle, we would meet, make quick decisions. Our IT builders would turn it around, and then we followed a cadence on a monthly cycle to get these changes out over a period of time. So in the end, and we're still in continuous improvement mode, but after 2 years of improvement, we have significantly reduced our time in the EMR in a 12-hour shift to hovering at about 135 minutes per shift. So we significantly shaved about 40 minutes for our nursing staff to give time back to spend with their patients, just time for themselves to take breaks, things like that. So we're pretty proud of that accomplishment. 2 successes that I would attribute to is definitely our executive nursing leadership, and that still continues. We still have high engagement month over month. We meet monthly to review optimizations. But secondly, the organization went through an effort to shore up the governance structure with technology. So we have a domain structure that has representation over 5 domain area service lines, departments, that ingest requests and gets prioritized, and we communicate between each other. So if Periop wants to implement something, we have a mechanism in our IT tool to communicate to our nursing domain to see if that's something that we support. So a lot of that is happening kind of behind the scenes without having those kind of meetings. So, and then also I just wanted to highlight, we joined KLAS about 2 years ago. It was our very first survey, and we're pretty proud of the results. Surprisingly, we're just like, oh, how are we going to fare out here? But we had a great, net EHR score. Our nursing, colleagues scored pretty high, I think about 83%, and a 97% likely to stay at our organization. However, there's definitely improvements in the support and training realm, so we are focusing efforts on, to support that, what we can do differently. So that's kind of our story.
Great. That's great news. Good to hear. I know they must love having that smaller amount of time because you always hear about how much time I'm spending in the EHR, and then I can't deal with my patients, which is what I got into healthcare for, is to take care of my patients.
And because they've seen those changes, they tell their friends, and our nursing informatics council is pretty open, so people kind of come and go, but the word is out, and so they know that their requests are being addressed. So whether it continues forward or not, but just having that voice and being heard.
Well, and we see that in the ARCH data that the question that we ask, do I feel like the organization in IT is doing everything they can to train and implement, which basically comes down to, am I trusting the organization that they're doing what they can to make my life easier? The higher that score is, the lower you see burnout. So there's a definite correlation there that you've tapped into.
I guess I'm next.
You are
Yeah.
next.
Yeah,
We'd
yeah,
love
thank
to
you,
hear what's
thank you.
going on
Yeah.
at Dayton Children's.
Yep, yeah, thank you. So Dayton Children's is a relatively small organization, and in some ways, it's quite interesting to see even organizations 2 times, 3 times the size of us having some of the same challenges. So in some ways, it's nice to know that. In terms of specifically what we're doing, we have the privilege of having a chief wellness officer, and actually we had that in place even pre-pandemic. So one of the things that had actually done is I have somebody, to sort of bounce ideas off and sort of have a structured program toward burnout. One of the things he has done is actually done the AMA survey. I think it's called organizational biopsy or something. And that has been very helpful in terms of sort of highlighting some of the burnout issues. And one of the main advantages of that is that has actually empowered me as a CMIO, to go to management and say, you see, I've been telling you about this all along. This is hard data to sort of support that. So what has that translated into? That has translated into more opportunities to request for resources. And some of the changes we have actually made in the EHR, when we send out the message actually comes from both of us, not just the CMIO, but guess what? The wellness officer. So what that does is it, sort of tells people that, listen, we're listening to you. These things are important. Some of the additional things we have done is feedback. We all hear about the black hole, the nurses, providers, they all complain that, what, we made a suggestion, nobody has heard the suggestion, what the heck is IT doing with it? And one of the things we have tried to do is make sure that when changes occur, we actually go back to those who have actually made the changes. That, what, your suggestions were heard, this is what we have done. Yes, we can't fix it today, but guess what? It's coming down the line. And again, it's just sort of fostering that culture that you're being heard. Things are not just falling off into a black hole. And obviously, there are some things that we cannot do, and we're just open with it. But at least, again, the message is heard that we're hearing them, and that you get anecdotal feedback that, oh yeah, thank you. We felt heard.
And you're also doing some provider-to-provider training, right? That you've seen impact burnout, correct?
Correct. I go back to some of, as you had mentioned, you have physician builders, and you brought up an important point, that these physician builders, they have to generate the RVUs. So while they are interested in actually helping the system get better, it's a challenge to actually deploy them, simply because, again, the RVUs, they have to be productive. So some of the things we have done, actually over the last 8 months, is we put together a provider-to-provider training program. I've heard different variations, but what we have done, and what seems to be working so far for us, is this is just a 1-hour session. It's online. Myself and a colleague who is very interested in informatics sort of co-lead that. And providers, whether they have the time or not, some, dial in during that 1-hour session. And generally speaking, what we'll do is we'll pick a topic, in-basket management. Hey, this is what you could do to improve how you manage your in-basket. These are the tips and tricks. One of the things we have also done is making sure that our trainers, some of our IT folks and some of our CIS folks actually are on the call. Because invariably, even if we say, listen, what we're dealing with today is in-basket, guess what? Yeah, my note from 2 years ago is not working. How can it be fixed? But since we have other colleagues, i.e. our IT and Epic analysts on the line, we're sort of able to say, hey, okay, yep, you know what? We'll connect you with XYZ so that is taken care of. We've actually had some slicer dicer training sessions, And each and every time, when we say slice the dicer, in basket comes up, or how do I use this button, or but bottom line is it's an avenue for concerns and complaints to be heard, especially for those busy physicians who don't want to pick up the phone. And so far, so good with the provider-to-provider training. We actually set it up so that we can almost get what I'll call instantaneous feedback. Just put it in the chat, and our trainers are actually monitoring that chat to make sure that some of the issues are taken care of. So we'll see how it goes. We're pretty happy with it so far.
Yeah. Great. So all of you have brought up something that was on my list of things to ask you about, and that's really about, how do you get the funding and the resources to be able to do what you need to do to be able to combat burnout and turnover? We know healthcare budgets are very tight right now. So Michael, I'd love to hear from you kind of what the AMA is working on, what strategies you suggest to your members, if you have any like that, ROI. And then love to hear from the panelists, how have you approached this with your management, and how do you make your case, and what's been successful and what hasn't been so successful? So Michael, if you want to kick us off.
That's great. We've built a number of resources and tools specifically to help physicians build that case study for leadership around arguing about why these investments are wise for the institution. That includes, how to build the evidence case, and part of it is doing the survey work and getting the feedback so you know the situation of what your clinicians are going through. We also have an ROI calculator that calculates the cost of burnout to your institution. You can plug in the size of your institution. And I believe that that calculator undercounts the actual cost, because that is really based primarily on turnover. We know the high cost of turnover for clinicians at all levels. For physicians, it's hundreds of thousands of dollars. When you talk about recruiting costs, the patient care that's not being delivered, and even when a new clinician joins, the ramp-up time before they get fully going. That doesn't account for potential medical errors, poor quality scores, patient satisfaction scores, because the clinicians were less engaged because they were burned out. So you can build that case, and I think when leadership sees, hopefully leadership knows that this is important. You don't need to make it, but there are people who are going to need the dollars and cents, and you can put that in and make that case that these are small investments, can have huge impact to your organization. And if you can just look like you've decreased turnover, that in of itself is going to be a huge financial driver for your institution.
And as Michael mentioned, the median time to recruit a PCP into the system is 6 months, a specialist around 15 months. And we showed the attrition, just the turnover. It cost us $500,000 for a specialist recruitment and attrition, and around $250,000. Even for the APP, that's around $75,000. So it's very clear, you can connect both dots together, and we showed clear ROI. That was the final straw, which board said, there's no choice here. And we got approved for it. It's a small budget, but I think we are using it successfully.
One of the advantages I have is my boss, the CMO, really understands and appreciates this as a practicing clinician. So he has given us any opportunity we have to present to the senior leadership team. We've really taken advantage of that. Obviously, collaborating with the chief wellness officer that we have is very, very impactful. And frankly, oftentimes you have to just plead and beg that, hey, we need this, right? And that's true. You plead and beg. And I can't underestimate the importance of being strategic in sort of making those calls or trying to make a need, bringing it up to senior management team. It's not unusual for me to walk up to one of my colleagues, division chief of, as an example, hematology oncology, and say, hey, listen, you guys are very important. Everybody likes to understand how cancer is being taken care of. Our CEO is very interested in that. And I'll say, hey, this is a resource that we need. Anytime you have a word with the CEO, please plug it in. The same thing for our surgical colleagues. So the idea is to sort of build a coalition, if you will, and collaborate with key providers in the organization to sort of make that push. And for us, it's worked quite well. And I cannot overemphasize the importance of making sure that when you're making a plug for a resource, always tie in our nursing staff and other clinicians in the hospital.
And I would say from a nursing recruitment retention perspective, we're a magnet organization, so that definitely does help. But as far as retainment and engagement, we have a honor nurse program where we have resources that apply to support the technology, and they're compensated accordingly. So that's working well. And again, kind of looking back what I said earlier, I believe it's a tribute to the high engagement that we have month over month, reviewing our optimizations and having that voice at the table.
Mm-hmm. And you have very senior leadership on your governance
Absolutely.
structure? Mm-hmm. Great. And something you said I wanted to pick up on as far as a chief wellness officer. I'm curious, how many organizations have a chief wellness officer? So just a handful, really.
Yeah.
Does everyone here have one?
Yes.
Okay. So how big a role is that? How important is that? Are you seeing that become more and more the standard norm? Kind of what can they do to help? And is that something that you need? I'm curious for the people in the audience. I mean, I know what I think, but I'm just curious as far as what you guys are seeing and how that helps you to move this forward.
I would say it's very important. And full disclosure, our chief wellness officer is also a clinical informaticist. So he gets it, he understands it. We collaborate very, very closely. I pull him in every opportunity so that, again, when the problem is, or the challenge is, when the challenge is sort of highlighted by two separate, the chief wellness officer and the chief medical informatics officer, hopefully it carries more weight. And that has helped, not just in the informatics realm, but also when we also partner with our IT colleagues. So I would say it's been very powerful, very helpful in pushing and driving for change.
Mm-hmm, mm-hmm.
There was a recent study published in the Joint Commission Journal that did a survey of all major health systems and hospitals about where they are in their wellness journey, and it was surprising how low some of the numbers were, even for hospitals with 500 beds or more. There was questions about, in the last 3 years, have you surveyed your physicians around well-being? And I would just intuitively say, well, that's got to be over 90%. And the numbers were closer around 50 to 60%, about 25, 30% with CWOs. But that is a journey, right? I think, if you don't have a CWO, do you have a well-being committee? Do you have a group of physicians, clinicians, nurses, others who are part of a team to work on well-being? And that's usually how the CWO eventually becomes, by you start with that committee. So if you don't have a CWO, but you also don't have a well-being committee or a group working on it, I mean, that's usually a first good start to get down onto that journey.
And as Michael mentioned, we did not have a CWO until 2019. The Physician Wellness Committee or the Medical Staff Committee, and I think their scope of work was mostly on disruptive providers rather than addressing the wellness. And we realized that, we have to address the burnout. And that starts with surveying the provider first, and we use Stanford model for surveying providers. It has really done wonders for us. Now she's involved. By the way, she's an organizational psychologist. She's not a physician, and she's involved in the entire recruitment process, also for a residency program. She's with the screening of incoming residents, and we've seen positive outcomes out of that.
Mm-hmm, mm-hmm.
And likewise, in our organization, we have a chief wellness officer too, very engaged. She's a PCP as well, continues to work, but has a very robust program, diversity inclusion groups, Wellness Wednesday webinars, very engaged in coming to committee and councils to talk about what programs are available, just getting in that engagement. So definitely very positive responses.
that brings up something else we were curious about in terms of, we've been talking a lot about EHR efficiency and how that can really help with burnout, but what other programs are your organizations doing that you've seen good results from, that physician and nurses are interested in doing, and then kind of what has been out there that's really not moving the needle any? Or can you speak to that?
Well, at our place, we have something similar to wellness.
Like Wellness Wednesdays,
Well,
what's
something similar to Wellness
participation?
Wednesday. I'm forgetting what the title is. We actually have a resource, and this is fairly recent. She's not, maybe you may call her a therapist, who actually is made available to the entire clinical staff, completely confidential. And she actually rounds around the hospital to sort of address these kinds of issues. We have a place we call a nest. It's almost like a Zen zone where you can relax during the day. So there are a whole list of programs and activities. I know we do offer yoga and a massage, so a whole suite of activities and programs to sort of address wellness and burnout. And my understanding is the utilization of these resources has actually increased. And for the few folks I know that have used it, they actually give it 2 thumbs up.
Great, great.
I think that's an important point that was brought up there. When you think about addressing well-being, and I think about it holistically, you can work with the individual clinician, like offering yoga or mindfulness programs. You can work at the institutional level, eliminating some of the EHR burden, and then there's sort of that larger societal, larger U.S. healthcare system level, and if you talk to any physician, they'll tell you prior authorization and payer burdens and things like that. And so in putting together a plan, thinking about all of those, and you might say, well, we're a local institution, how can we influence government policy or payer policy? Well, you have congressional staff that represent you, and are you advocating for them, about legislation that's going through Congress? And there's legislation going through the U.S. Congress to right-size prior authorization for Medicare Advantage plans that's sort of been, held up in Congress. So you can think about putting a plan together to work with each. I would just caution, though, if you start with the individual and only solely with the individual, sometimes that can backfire because it can come across that you're blaming the individual. Just do more yoga, just do more mindfulness. And that's an important part of the solution, but it's got to be thought of as a holistic, portfolio of offerings that you can let your care teams know. And we're working on all these comments. Yes, we've got yoga, we got mindfulness, but we're also trying to eliminate and decrease your inbox burden. And we're trying to work to eliminate the prior auth burden with some legislation and all the things in between.
You bring up a good point. We're looking at anywhere we can insert automation and that efficiency to, taking a look at features and functions that we probably didn't have an appetite before, but just kind of getting our heads wrapped around that. One of the projects that we did was the deterioration index scoring. Knowing that our workforce got less than 10 months of experience using functionality to assist in some of that surveillance and that tap on the shoulder for our new young nurses. As well as we're getting our toe wet with virtual nursing, so looking at other programs to kind of help support the workforce and reducing that burden and promoting that wellness.
Great, wonderful.
Just one thing I want to add,
Yeah, go ahead.
in all of your institutions, if you want to move the needle on burnout, have that as a measure in your balance scorecard for the organization. That is a critical piece because it's non-revenue generating initiative, and unless it is at the highest level of the organization, you will not see a meaningful change.
That's a great point.
Excellent point. I know we have less than 10 minutes left, so I'd like to open it up. I see a lot of people, I think, want to ask some questions. We have a couple of roaming mics, so if you have a question for the panel, just raise your hands. They'll bring you a microphone. Over here, we've got, I was like, somebody has to have questions.
So thank you very much. I'm from the University of Utah Health here in Salt Lake City, so I didn't have to drive very far and already adjusted to the altitude. So really appreciate, Michael, your comments and looking at the entirety. One thing I would suggest, and I think and I would love to hear kind of how the panel's approaching some of this too, is at Utah Health, one of the things we focused on is looking at the total experience that occurs during the healthcare process. We try to encourage people that, yes, it's really important to look at the physician-clinician experience, address burnout and turnover. I mean, that's the essence of the panel. But if we do it at the expense of someone else, so at the patient level or another player, the employee, we may be short-term in our results, but not get the long-term results we want. So we look at that total. We're trying. We're not there. We try to look at that total experience and make sure that, I think you said you can't, if you focus individually, you may be missing the full picture, and you may not have the entirety, the outcomes you want in the long term may not be achieved. So I would love to hear how you balance that all out, and making sure that to focus on burnout, but at the expense of the patient or at the expense of the employee may kind of be damaging. So how do you balance it? And maybe some examples from your organizations.
Well, first I'll just say it's a great comment. You think about administrative tasks, and sometimes we talk about offloading administrative tasks. Well, that moves administrative tasks from one person to the other person. So is now one person more satisfied, the other person less satisfied? And some of that, I think, is thinking about different people's career tracks and how everyone can sort of skill up. But it also, I think, sometimes asks the question of, like, should we even be doing these things? And maybe it's not offloading a task to someone else. Why are we doing these tasks? And sometimes when you're in an institution for so long, it's like, well, we do it because we've always done it that way. And start to ask those questions, and so that everyone benefits from these efficiencies and programs. But it's a great point. Love to hear what others think.
Yeah, I mean, I just want to add, the provider engagement, employee engagement, and patient engagement, they're all directly correlated. So, I mean, any of those buckets will have a positive change on the other two. I mean, that's enough research published on that. I'll give an example is, we had one of the initiatives from the Builder program was to do something called pre-screen self-questions, which means that if the patient's coming for an urgent visit, they do a self-screening question before they come for the visit. That not only reduced the physician time, but also the medical assistant, who was spending around 9 minutes per patient, down to 3.5. So that was one thing which the IT tools can do it. We just needed some initiative to work that through. So I think the holistic approach is still important, and making sure that it doesn't impact somebody negatively throughout that.
Yeah, what I'll say is you're absolutely right. And just on a practical level, as an example, when it comes to documentation, the providers will say, oh, we don't want to do this. Guess what? Let our nurses do that. And one of the ways we have set up our governance is if certain documentation on the inpatient is going to change, and for the providers, guess what? We go to our nursing inpatient group to say, does this work for you, so that they're not offloading some additional tasks for you. So it's a balance. And I would just openly say we're not quite there yet, and we're just sort of trying to figure that out. But we're very, very acutely aware of making sure that that does not happen.
Looks like we have time for one more question. Does anyone have another question? Oh, yep, there we go.
Hi, thank you. I'm from Children's Healthcare of Atlanta, and really appreciated the panel conversation. My question comes from the IT perspective around something that I think the nursing officer said about automating things for your staff. And I think as we've found that if you automate bad processes, you just make bad things happen faster. So I was wondering, how do you collaborate with your IT groups, or do you, to ensure that the things that you are asking of your IT teams are actually things that increase efficiency and make things better for your folks?
Absolutely. So I had mentioned earlier, we as an organization went through a whole governance restructure to develop that structure, making sure that we have all domains represented. We have IT liaisons on that, as well as an informatics liaison, as well as these are all operationally led. So we kind of have that triad, and depending on the nature of the request, it will go through a level of intaking and an assessment by our IT colleagues, and then truly kind of getting to the crux of what problem are you trying to solve, answering those questions, going through a level of effort so that that information is returned back. So when you have your governance meeting, you kind of go in, with substantive information to have that conversation. Are we going to move it forward, or we didn't, fully understand some other aspects to a request. So that has tremendously helped. We're already probably on our 4th iteration of that, and we'll continue to make that better, but that has definitely helped. As well as above this domain level, we have a Transformation Office Council, so we have representation across the network. There's that visibility and conversation to some of those larger scaled initiatives and projects, so that other people can contribute. And obviously, if we need to escalate up, we have that highest strategic Transformation Operation Council level. So we have those checks and balances in place, and we're getting there, but that has definitely kind of improved and turned around a lot of the initiatives and projects at our organization.
Okay, well, we are out of time. Thank you again, panelists. It was a great conversation. Thank you for sharing your time and your experience with us. We're grateful to have you here. Hope you enjoy the rest of the conference. And looks like the doors are open, so I think there's a few minutes for you to grab water, a snack, and get to the next meeting. Thank you so much.